Hi, everybody. I am just a supplementary, and it's actually a dictation to cover what should appear in week 8 because there are no YouTube presentations, but this will be one, obviously, for it. And this involves this, and I sent the link to the current class, and I'm happy to send it to everybody else, so I will include it. Uh, on that week 8, just a link to this particular. This is from SlideShare. SlideShare is very useful if you're interested. The only trouble with this is they have commercials, so I mean, so you can download it, but I think the commercials come with it. Don't know. So I'm not too worried about the download. I suppose I could do that differently, but who cares? So, nevertheless, this is where we start. Premise, or a preface rather. Total body irradiation is something that's used more today than it used to be. It, there are certain kinds of leukemias that it's used for to really suppress the bone marrow, and and some kinds of cancers. But the interesting thing is it's used more today for bone marrow suppression uh, in preparation for bone marrow transplantation, which is used much more today than ever before as we become more familiar with the technology. It's probably something that started 40 years ago or so, and now and I'm not that up with the advanced techniques of how there are better ways to obtain the bone marrow. There are better ways to uh, be able to prepare the bone marrow for eventual implantation. So effectively, you want to sterilize, if you want to use that term. You want to eliminate the bone marrow that's the problem at, let's say, in different kinds of leukemias or bone marrow related cancers. One of the folks who works here, her husband, unfortunately, no longer with us, uh, and had two bone marrow transplantations for a disease entity you'll see here called multiple myeloma. And again, these are unusual conditions. Many of them, they're not. I don't know that they're common, but they're not uncommon. And there's a lot of things that I think you're seeing a lot of diseases, a lot of different kinds of anemias that potentially. And so it's a very interesting area. So this is I'll just scroll through these and try to narrate a little bit. You can see this use of the total body irradiation. Let's say been around for the better part of 70 years. Nobel Prize winning rationale uh, for use has really not changed. You want to, there's different ways to do this, and we know a lot more about it with regard to techniques and things like that. So it's a component of, and when they talk about, most things, when you talk about interdisciplinary these days, a lot of people work together to try to develop the best options for treatment. So leukemias, lymphomas, solid tumors, all of those kinds of things are are really significant. Okay, and you have people doing surgery, people doing radiation, oncology, hematology, transfusions, overall medical things like that. So when they say myoablative, when you ablate something, you remove it, and immunoablative conditioning therapy prior to stem cells. So here you're trying to suppress the immunological activities of the body in an effort to be more receptive to stem cell transplantation and and effectively bone marrow uh, is really an example of maybe the start of stem cell transplantation, and we're going to hear a lot more about stem cell products as time goes on. So you eradicate the bone marrow, uh, the, the impact that the tumor is going to have, immunosuppression, lymphocyte elimination, so it allows for grafting of the donor bone marrow. Because if the white blood cells are there, particularly the T cells, I mean, this typically marrow is donated, and your body is going to view it as foreign, and there's going to be an immunological response. You want to suppress it. It depletes it in a sense that now that effectively there's room for it, and certain cells with genetic disorders, and you can look these up, but there's a lot of different anemias. Uh, Most of these are associated with genetic defects in manufacturing certain clotting products or in causing irregularities in the structure of the blood cells themselves, be the way to look at it. And you can see the commercials which we're going to come with. So this is different things. You can use it in leukemias. You can use it in lymphomas. And when they talk about a leukemia, it's effectively a bone marrow cancer. A lymphoma is, think of that as a proliferation of cells in lymph tissue, which is basically lymph nodes, which you and I would call swollen glands, and then the manufacture of these abnormal cells. And then there's that multiple myeloma where it's in multiple areas. And we particularly see it in and around bone marrow in that regard. Very, very much so. Every so often I get a ding, I have to pay attention to it. So here are some pediatric tumors, some adult tumors. When they say solid, it means it's not got fluid within it that's there. Uh, and you can see these are some interesting other, with effectively non-malignant. They're not necessarily cancer associated. Aplastic anemias can come from over certain kinds of medications can cause it as a side effect. Notoriously, there were some antibiotics that were effectively banned because of that, just for informational purposes. Okay, high risk acute and chronic myelogenous in first remission would be something. Second remission, they're giving you the ideas, all the types of things that are there. And I don't think that's a big deal for us. I think we want to know more about it just for advantage. There's no sanctuary sites, meaning that everything is effective, independent of hepatic and renal function. So they're going to function without this, and they're going to be able to utilize it in their case. Uh, doesn't really matter what the amount of blood supply to the particular tissue. There's not a difficulty with excretion or so it's not like you're introducing a toxin. You're just basically clobbering the bone marrow, and you can shield certain areas and not shield certain areas depending because you're using radiation. So you can keep things obviously. Gonadal tissue would certainly be shielded as much as possible. So, unfortunately, these are some of the problems. You're going to have to protect the eyes. You're dealing with potential sterility. Uh, I'm sure when you're dealing with children with some of these leukemic problems, dealing with bone marrow and growth factors could be a problem, and whatever impact it might have neurologically. So you have to deal with those kinds of things. Again, interdisciplinary approach. Uh, you're looking at the transplant areas need to be in close proximity, and what you're seeing a lot today, and the best way to phrase this is we're seeing a lot less surgery in hospitals. Now, this would obviously be a hospital-based procedure, but there are certain areas that are reserved in hospital environments as clean areas where they don't put a lot of people with infections when they're having to deal with bone marrow transplants or liver transplants, for instance. And it really just because it does, or they have a major surgery with a lot of potential for infection. Okay, and then they go through the physical examination that's there. Okay, and these are just various types of factors that you're looking at without going crazy about all of the things. You get various kinds of organs. This would be liver function. You're going to be filtration rates involved in the kidney and various transport rates, just to make sure that there's certain criteria that have to be met that are part of it. So obviously, you want to have it. You want basically the patient to be able to tolerate it. To do it, you can continue to use the same technique, positioning and stability, to deliver the prescribed dose to the entire body in a uniform manner within certain parameters, which is either 10% and optimally 5% if you're able to do so. And they're just showing you some of the illustrations where we can see this that are here. And I don't know how much they apply to you. Uh, so here you're looking at whether this is bilateral, meaning you're trying to get it on equally on the same size, and they're showing you some positioning. Patient sitting or lying down on a couch, good comfort, the variability of the body thickness you have to compensate for. So there are certain techniques that are involved in this. I'm not that familiar with this. Most people who have experience in that field. I'm trying to give you an idea. There you have anterior, APPA means anterior to posterior and posterior to anterior. And having somebody standing erect like that. And again, this would be not homogeneous, would be think of as a uniform distribution. Standing TBI allows shielding of certain critical organs, boosting superficial tissues into the shadow of the blocks with electrons. So there's certain things that you can do to deal with this, which I think is valuable. Uh, I'm not getting into the machinery and the different kinds of beams. I think that's something that would deal with you technically. Here's something from McGill University with a sweeping beam technique. You have McGill's up in Montreal, very well known university. And you can see where here they're giving you an illustration of this. What's used, there's various kinds of methods, looking at the different beams from different numbers of sources, whether it's a single source or horizontal beams or a variety of different techniques that are there. You might find that interesting. Again, some of the technology that there. Typically the patient, in this case lying supine, they give you an idea of roughly what their length of the patient, not more than 140 centimeters. Uh, if the length is greater than that, then they have to do something with regard to the legs. 140 centimeters isn't, 100 centimeters would be, for instance, would be 3 feet 3 inches. So, I mean, a taller person, you might have to make some adaptations for with regard to that. And there you can see, collimation is done as is typical. Various measurements have to be done. And this is the idea of what you're trying to approach. And these are some of the doses. And again, that's not my area of expertise. As you can see, high dose versus standard dose versus lower dose, and the lung being the dose limiting organ, and that's why I obviously fractionating it over a period of time. Okay. And when they're looking at a reference point, mid abdomen, roughly the umbilicus, your belly button, and apparently that's internationally sterile conditions, delivered in the position which measurements are taken, smearing the lungs, various ways that devices used for measuring and their placement, as you say, skull, uh, mediastinal region, head and neck region. That's what H and N is. And you have to compensate for contours in various areas. I'm just showing you that. I certainly would look at the complications, and these are consistent as we've discussed and has been presented previously with regard to the damage to the lining tissue, gastrointestinal, nausea and vomiting. Headache is there's so many different causes of headache. So it can be circulatory, it can be fluid and electrolyte balances, it can be to some extent a response that we get from nausea and vomiting. Fatigue, certainly because of bone marrow suppression. There's obviously an impact on the eyes, inflammation of the lining of the esophagus. That leads to appetite. Your skin, there's going to be an increase from that kind of radiation with redness, which is the way they used to monitor it. Irritation of the mucosa, the linings, diarrhea, fever, all of those things are part. I mean, it's a major injury. There's no two ways else to look at it, I think. Almost done. So, cataract, dryness, keratitis. So, we're looking at dryness in and around the eye and potentially cataract formation. Dental caries, tooth abnormalities, xerostomia, dryness of the stoma of the mouth. And so that's from salivary gland suppression. The salivary glands play such a vital role in keeping everything really functioning as we pass things into our mouth. And so they guard so many things that guard against cavities and irregularities that are there. Lung damage, liver damage, kidney damage, abnormalities in children, obviously sterility, endocrine abnormality, and when they take meds, they're talking about metastases. If for some reason this has, let's say, fragmented a tumor, I would suppose, and it moves. Okay. Conditioning for regimen for, so this is a part of that for skeletal bone, which is where the location of multiple myeloma is. Bone, major lymph nodes, liver, spleen, certain sanctuary sites for myeloid. And so it's think of it as being diagnosis specific, and it may be something that you'll have to be familiar with. So, and this is something, and I'm unfamiliar with it, called tomotherapy, delivery to desirable to deliver radiation only to the immunological structures in the bone marrow and spare sensitive areas. Uh, and I guess it appears to be positionally based. And they're giving you some of the ways that it's done. I'm familiar with it, so you can read through it as well as I can read it. And that's everything for that. So I did want to present that to you. It's a comparatively limited presentation. This is another one that involves effects. It's really very much shorter. I will present it to you separately. It's troubling because a lot of the information we have gotten are from these areas. And I've commented on those if you listen to the other presentations that are there. We've learned more about it from Hiroshima, Nagasaki, and Chernobyl, uh, from the effects of these massive amounts of radiation, either by accident or by intent, without getting into any of the nuances or the what occasioned those events to occur, and fault or blame, because it's really just trying to understand the effects of radiation and really this aspect of the course. So thank you very much. I'm going to conclude this. I will upload this for you. Again, if you have any questions on any of these areas, it's simple enough to, we can meet virtually. You can contact either Dr. Buxton or myself or whomever is running the course. If we've just set up the shell, but was I likely for the next few times that this will be offered, I suspect Dr. Buxton and I. So you know our emails on the syllabus, and thanks again.